All right, let's get going. Thank you so much for everyone's patience while I figured this out. And thank you so much for Dr. Lebowitz, who agreed to take the time out of his schedule to have this discussion. I heard about Dr. Lebowitz a while ago when I was getting trained in PCIT, which is a therapy for more kids with difficulty with behavioral issues. And Dr. Kurtz, who trained me, said there's this other great therapy that also really works to empower the parents to help with childhood anxiety. And then as soon as I learned that he was giving his training for SPACE, which he'll explain what it is shortly, I was happy to take it, and he agreed to speak with us. So I'm so excited to have Dr. Eli Lebowitz, who is an associate professor at the Yale Child Study Center, part of the Yale Medical School. And he recently, and together we'll be speaking about SPACE for a little bit. And please, if you could just let us know what SPACE is.
Well, first of all, thanks for having me, and congratulations on this series, which I'm honored to be part of. SPACE, which stands for Supportive Parenting for Anxious Childhood Emotions, is a parent-based treatment for childhood and adolescent anxiety and obsessive-compulsive disorder. And what I mean by a parent-based treatment is very simply that rather than working directly with a child or adolescent to help them overcome their problem, SPACE works entirely through parents, but the child is still the patient, meaning that is the person who we're trying to help. And so SPACE is really unique in being a treatment that is my video go off? It's really unique in being a treatment that can work entirely through parents, which, among other things, has the advantage of being able to provide a treatment even for children or kids who are not themselves able or willing to participate directly in therapy.
Okay, awesome. So that's something that comes up a lot, is the idea of, kids who have a hard time engaging in therapy. And, I definitely agree that it's so helpful to have a treatment that doesn't require, the child's presence in the therapy session itself. Speak a little bit about the, it is an evidence-based treatment. If you could speak a little bit about the evidence behind it, that would be great.
Mm-hmm. So the evidence for the efficacy and efficaciousness of SPACE is growing rapidly. It's a relatively new treatment. It's a novel treatment approach. And so the evidence continues to grow. The first steps in establishing any new treatment are really to determine whether it is a feasible treatment, whether it's an acceptable treatment, whether or not people will actually participate in it, whether they feel satisfied by it,
not right now, pumpkin.
Things like that. And to do that, we conducted a number of open trials. So these are smaller clinical studies that give us that kind of information. Once we were able to establish that, in fact, it is a feasible and acceptable treatment, we then move on to actually determining the efficacy. And that happens through randomized clinical trials, randomized controlled trials, where we're able to compare the efficacy of SPACE to other treatment approaches by randomly assigning families to get either one treatment or another. So for example, in a large randomized controlled trial of over 120 children with serious anxiety problems, families were randomly assigned to get either cognitive behavioral therapy, which is done entirely through the child and directly with them, or to receive only SPACE with no direct contact with the child themselves, apart from assessment and evaluation. And results from that study really provide the strongest evidence to date for the efficacy of SPACE, because in a nutshell, there really were no significant differences in improvement in child anxiety and the number of children who remitted from their problems, meaning were essentially cured of their anxiety disorders, or who had major and significant improvement in their anxiety symptoms. There really were no differences between children who got cognitive behavioral therapy, which has long been considered the gold standard evidence-based approach, and children whose parents participated in SPACE. And so our confidence in the efficacy of the treatment just continues to grow, and additional clinical trials are underway in multiple locations to continue to develop this evidence and add to it.
Okay, and thank you so much for sharing that. It is exciting to learn about all the research that's underway. I was curious if you could speak momentarily about the evidence for its use for OCD. I'm just going to admit the individuals who are waiting. Hold on one moment. I thought they would just be viewing. This is the first time I'm using this, a public apology for all the tech issues. This will be recorded, and I'll cut out this stuff, so excellent. Okay, so as far as research pertaining to its use for OCD, if you could speak a little to that.
Yeah, well, one thing to have in mind, I think, and remember is that treatment for OCD and other anxiety disorders tends to be quite similar. That's true for pharmacological interventions, where the frontline medication choice tend to be largely similar. It's true for cognitive behavioral therapy, where treatment of anxiety relies on very similar principles of exposure and cognitive restructuring. And it also is true in SPACE, where similar treatment components and elements are applied. And so the treatment is actually quite similar, which means that we can learn a lot from research on other anxiety and apply to OCD as well. However, we also have done work specifically looking at the intervention in OCD. Part of that is clinical experience, which has mounted over the years, and just gaining experience in working with families of children and adolescents with OCD. And another part is a clinical study that we published focused specifically on OCD, where again, working only with parents of children with fairly serious and severe obsessive compulsive disorder, there were significant gains. What we don't have yet and are working on now is a randomized clinical trial specifically for OCD, and this is an important next step in developing that evidence as well.
Okay, and thank you for that. So if someone has a child with anxiety, how would they go about deciding which intervention, given the similar results between CBT and SPACE, how would they make this decision? What kind of factors would play into it?
Well, to some extent, that is a personal question of preference. There are going to be some cases where the answer is quite obvious. So for example, if you have a child, as many children who is not really a candidate for individual therapy themselves, well, then the decision is easy. Of course, a parent-based intervention is going to be preferable in that situation. That can occur because of a child who is unable to participate directly in treatment because of various problems. It could be communication-related problems or others, or it can also be a child who's unwilling. Cognitive behavioral therapy, which is really the child-based alternative, right? Exposure-based cognitive behavioral therapy is the treatment of choice when working directly with children. And it requires a high degree of motivation and collaboration on the part of the child in order to work. It's not a treatment that you can just do to someone unless they are a willing participant in it. And so in cases where that is not an option, a parent-based treatment like SPACE is clearly preferable. In a situation where that's not the case, and a child might be willing to engage in therapy themselves, you don't necessarily have to be picking one or the other. You know, I described our randomized trial as being clearly split between either you get this or you get that, but that's partly driven by research questions. In order to be able to compare efficacy of two treatments, you really have to keep them separate and only do one or the other. In clinical practice, as the parent of a child with anxiety or with OCD, you don't necessarily have to be making that either or choice, and can have an integrated treatment strategy that includes both work with a child directly and work with parents in space. Sometimes it will make sense to do them at the same time. Other times it might make sense to sequence it. So doing parent work first and then working with the child, or in other cases, working with the child first and working with parents. And I think consulting with a knowledgeable clinician who has experience with both approaches is the ideal thing, so that you can really make a plan that works for that particular family.
Okay. And perhaps you could walk us through the basic components of a SPACE. Like, what does it look like, you know, from the point of, you know, a parent comes to the clinic with their child who's experiencing, let's say, social phobia, or let's do, let's use OCD as the example of, like, from start to finish, what that would look like.
Well, so before walking through what will it look like in practice, I'll just say a few words about some of the underlying principles that guide the treatment, and then
Sure.
it will make it easier to understand why it looks the way it does, if we understand why, you know, where we're coming from and what drives and informs this treatment. Because SPACE is a treatment that really takes a significantly different perspective on child anxiety relative to other treatments. In many ways, most treatment for childhood anxiety or OCD looks very much the same as adult treatment of anxiety and OCD. The way we talk to children and the words that we use to explain things can sometimes be different in order to tailor it to a developmentally appropriate language. But the underlying principles are largely the same, meaning we think about the ways in which a child's thinking might be biased or skewed or maladaptive, and we try to correct that. And that's true in cognitive behavioral therapy for adults, and it's true in cognitive behavioral therapy for children. We think about the way that avoidance is maintaining symptoms, whether that's OCD or another anxiety problem. We know that avoiding things that you fear or that trigger your symptoms tends to maintain those problems over time. And so we engage in repeated and gradual exposure to those feared situations or to those obsessive compulsive triggers. And that's true in adult cognitive behavioral therapy, and it's true in child cognitive behavioral therapy. And so when it comes to the CBT, what we have done is essentially to repackage treatment that applies in adults and apply it to children. And that works. It works very well for many children, but it also leaves out some unique aspects of child anxiety and OCD that are meaningfully different from the way these problems manifest in adults. And those are the aspects that SPACE targets. And primarily, what it leaves out is the role of parents, because children naturally respond to fear by relying on their caregivers to cope with whatever it is that's making them anxious or distressed or upset. That is literally in our nature. We are hardwired to respond to fear as children, not in a personal, kind of individual self-defense kind of way, but to signal our caregivers when we're feeling anxious. And so a child who is socially anxious relies on caregivers to help them to avoid the things that make them anxious. A child who is worried relies on parents to reassure them and help them to feel better. A child who has OCD relies on parents for help in doing rituals or in reassuring them. And that means that parents, while by no means the cause of anxiety problems in children and adolescents, and that's a very important distinction because I'm really not trying to suggest that parents are the cause of these problems, which they're not, but they do get sucked into them. Meaning if you are the parent of a child with an anxiety problem or OCD, almost inevitably, you are engaging in behaviors that are intended to help your child to feel less anxious. Those behaviors we call accommodation or family accommodation of anxiety or of OCD. So for example, for that child with social anxiety, an accommodation might be to speak instead of them in a public setting because they're anxious about speaking themselves. For a child with separation anxiety, it would be to stay near them when they're anxious, or to answer the phone many times during the day because they're anxious about separation. For a child with generalized anxiety, it might be responding to reassurance-seeking questions, to worry questions. For a child with OCD, it might be engaging in rituals together with the child, listening to a child's obsessive confessions that they do over the course of the day, often for significant amounts of time. And the same for any anxiety-related problem. Almost invariably, we have a lot of research to support this, almost invariably parents are going to find themselves drawn in to accommodating their children's symptoms. And much like at the individual level, avoidance tends to maintain anxiety, even though it's helpful in the very short term to feel better, but it tends to maintain the anxiety over time. In a very similar way, accommodation by parents also helps to feel better in the very short term because I'm able to avoid the thing that's making me anxious or to alleviate the worry, but tends to maintain the anxiety over time and is strongly linked to more severe symptoms over time, to greater impairment by for the child and for the family. And importantly, high levels of accommodation are also linked to worse treatment outcomes. And so this has been well established in OCD in particular. It's been well established where it's been shown that if a child is heavily accommodated by parents, the likelihood of them responding to cognitive behavioral therapy or even to medication is significantly lower relative to a child who's accommodated less. And so this is an aspect of these problems that is really prominent in childhood and adolescence and is meaningfully different from the way these disorders manifest in adults. Not to say that there isn't accommodation of adults, but children are just inherently driven to rely on parents for accommodation, and parents are powerfully motivated to provide the accommodation. And that is where SPACE comes in and focuses the most. And so there are really two things that parents learn to do in SPACE.
Right. Hold up one moment. I'm just hearing, is that coming from your end, my end, or is there
what is that?
Someone in the crowd who is kind of playing some drums? It seems like they're all muted.
No, it might be the rain outside my window to be.
Oh, okay. We'll blame that one on the rain. And
I guess sorry, but I hear it also. There's quite a bit of rain right outside my window, and it's coming down on the I think on the air conditioner. So
right. Okay. Well, we'll try our best. Hopefully, this series will continue getting fancier and fancier. But we are kicking this off with an awesome guest. I'm so happy he's here. And I think you brought up like a really great point about moving from accommodating anxiety and providing support. And, some therapists, who I've spoken to have mentioned like, I already instruct parents to, not accommodate the anxiety as part of my treatment for anxiety. So what would you say to, therapists who say that, as well as parents who are, either looking for treatment and their provider is saying like, oh, I do that as well. Like how, really, I guess the question is, what does SPACE add? And yeah, that's it.
Yeah, I would say something very simple. I would ask a simple question. If you tell somebody, try not to avoid, have you done cognitive behavioral therapy? Probably not, right? You've given some potentially useful advice. You've certainly made a recommendation in the right direction, but it's unlikely that simply telling somebody try not to avoid is going to meaningfully impact a serious disorder. Because in order to really do the therapy, you have to get into the nuts and bolts of it, right? Cognitive behavioral therapists know that doing CBT goes way beyond just saying don't avoid, right? It includes really mapping out and identifying the things that you are avoiding. It includes creating and constructing detailed hierarchies for exposure, practicing, going through all of those steps, troubleshooting the times when it doesn't go well, figuring out how to implement those steps outside of session as well as in. There's a lot that goes into cognitive behavioral therapy apart from the general advice of don't avoid. And I would say the same thing applies for accommodation. Meaning, if you work with families and you say, it's not helpful to accommodate, try not to accommodate, that's good advice. It's maybe a useful suggestion, but it isn't likely to have a significant major impact on the problem or on a parent's behavior. Going back to the question of what does space look like, there's a lot of work that goes into reducing accommodation, which is one of the big goals that we're trying to achieve in space. And so some sessions, apart from just orienting parents to this and helping to understand it, significant time goes into detailed mapping of all the different ways that parents are accommodating. It's not enough to simply say don't accommodate. It's not even enough to simply ask, how do you accommodate? You have to really map that out and spend time doing that. And then you have to take time to figure out what would be a good target to focus on, because most parents are going to be accommodating in multiple different ways. And it's not likely that they're going to be able to change all of them, or certainly all of them at the same time. And so you have to make some choices. What would be a good target to focus on? Having done that, you need to create detailed, pragmatic, and practical plans for how parents are going to reduce the accommodation. You have to think about what is the target? When are they going to do it? Who is going to do it? Is it just one parent? Is it both? Is it in every situation or only in some? Is it in the morning? But what about getting to school? Is it in the evening? But what about getting to bed? If you don't think through these questions, it's unlikely that parents are going to implement a plan with any real consistency. And you have to tell them what to do instead, because it's generally not effective to ask people to not do something if you don't also supply them with an alternative for what they're going to do instead. Otherwise, faced with the stress of a child who is visibly anxious or is upset or maybe is angry, you're going to fall back on the only thing that you have, which is right back into the accommodation, which then leads to the next point I want to make, which is you also have to supply parents with tools for coping with the reactions and responses that they're going to encounter from their child when they don't accommodate. Because children are often upset when they're used to being accommodated and they feel like that's the only way that they can possibly feel better. And now here's a parent saying, no, I don't think that's a good idea, so I'm not going to do it. A child may resist that change. They may get more anxious. They may get angry. They may say, you don't love me, or you don't care, or you don't understand. Or they may say, if you don't help me this way, then I can't go on living. I'll kill myself, which is an incredibly difficult thing for any parent to hear. And so the point, I guess, that I'm trying to make is there's a lot that goes into helping parents to make a consistent and significant change that is way beyond the thought, yeah, I also talk about accommodation in my work, or I also advise parents not to accommodate. If you give that advice, I applaud you. I think that's a good thing to be doing, but I think it's naive to think that that is in and of itself a substitute for a thorough program that can actually address this in detail.
Yeah, and I will add that as someone who has gone through the training, the tools really, seemingly can really make this happen, really give the parents what they need to do the things they, know that they should be doing and are struggling to do that. And I think these tools are, extremely effective and, intuitive and work. And I'm very excited to start using this when I'm able to. I'm curious if you could speak a little bit about internet delivery of space, right? Has there been, seemingly, in my understanding, most therapies that are shown to be effective, face-to-face, rarely is there a large difference between internet delivery, and I imagine space would be similar. Tell me about some of the studies that are looking into that currently.
Yeah, well, first of all, I agree with you. I think that has generally been found to be the case, that if you can do it in person, you can also often do it like this, like we're doing now, and have similar effects. And I would say that is probably true of working with children. It's even easier to do that when you're working with parents. And so, working with a child who's potentially a little bit energetic or kinetic and moving around or easily distracted or needs a little bit more touch and contact in the interaction may be a harder thing to translate into a tele approach, but even there the results are pretty good. In working with adult parents, the translation to like teleconferencing is actually easier. I think it makes a lot of sense, and I think it is also really important. Access to treatment is a tremendous barrier for many families. If you are lucky, you live in an area where there are providers in the vicinity near you, and maybe you're able to go, and even people who live in the areas with the highest density of mental health providers find it difficult to actually get into treatment. But that goes many times over for people and families who are living not in such high density mental health areas, often very far away from the nearest provider. And so being able to access treatment is an incredibly important goal. And it not only means that you can see somebody further away, it also means that you're cutting out so much of the unnecessary burden that comes with face-to-face treatment. Because if you don't need to spend the time on the drive there and on the drive back, you've cut out a lot of the burden. If you don't need to park, you've cut out a lot of the
no babysitters.
So there's a lot of value in being able to do that. In fact, one of the goals that we really, or one of the challenges that we really face as a society is actually enabling that more, including issues relating to legislation and licensure across states and issues like that. I don't want to get too deeply into, but that actually pose unnecessary hurdles and barriers for the dissemination of services to people who need them. It is important to say that it should still be a treatment session, meaning, yes, it can be like this, sitting in front of a screen and talking, and almost everybody today has a screen that is capable of doing that, whether that's on a phone or a tablet or a computer, but it should be a treatment session. You probably shouldn't be doing your shopping or your dishes or your house cleaning at the very same time, but it's still a lot easier to set aside that time in your day if you don't have to meet in person. In our clinical trial, in the clinical trial that my program is currently conducting, which is another clinical trial of SPACE, also including some neuroimaging before and after treatment to learn more about some of the brain markers and the change that actually occurs in a child's brain as parents make these changes. In that clinical trial, we give parents a choice of participating in person or over Zoom, just like this, over teleconference. And a large number of parents opt to do it in person, over Zoom. We have not yet completed that study, and so I'm not going to talk about actual outcome data comparing the two treatment modalities, because that will have to wait until the study is complete. But we're more than halfway through, and we do know from the families that have already completed treatment, and even just from the therapists on the team who are delivering the treatment, that it works very well. It's a popular choice. It works well. Again, without getting into actual empirical hard data, I will say that I don't think that there is a disadvantage in terms of outcomes, and there's definitely advantages.
Yeah. Yeah, and as someone who does internet-delivered PCIT, I definitely see that appreciation parents have to just be able to, do the work from home without, the schlep. And yeah, so I definitely am glad and hope to see it continue to spread in that way. I'm curious, I found it really interesting at the training, your discussion of the application of SPACE principles to various presenting problems. And one of the things you'd mentioned is, or discussed is like failure to thrive. Failure to launch, definitely not failure to thrive, totally a different type of treatment, but failure to launch. If you could speak a little bit to kind of how the SPACE principles are applied to that very difficult problem of adults really, having difficulty just getting past, that or getting into adulthood. And I found that to be particularly interesting, if you could share.
Sure. So failure to launch this is obviously not an official, diagnostic term, and maybe it's not even the best term to
right.
But what it really is referring to is a very serious and very common phenomenon, which is the phenomenon of adult children who have been unable to transition into functioning independently as adults. Sometimes that is, they have never made that transition into functional adulthood. Sometimes there has been an aborted attempt at transitioning, such as going to college for a semester and then coming back home and being stuck. I will say, I know this is recorded, so I should be cautious in my language, but I will say I see this issue of failure to launch as the last remaining completely unaddressed area in mental health. It's hard to think of another problem that is so unaddressed. There are other problems for which we don't have good answers, but it's usually not the lack of trying, right? We don't have terrific answers for serious eating disorders. We don't have terrific answers for a number of serious problems in mental health, but it's not usually for lack of trying. Whereas this is a phenomenon where actually it sort of is for lack of trying, because we're not devoting the energy and the effort to actually understanding this problem. And just maybe to exemplify that, we don't even know the actual prevalence of this problem. Nobody does. I know, and many people know, that it is a very common problem. How do I know this? I know it because my email inbox is flooded with calls or emails, obviously, and my phone is flooded with calls from families who have read a paper that I wrote or listened to a podcast that I did on the topic and reach out in desperation. And the reason that they're in desperation is because we do not prepare clinicians with tools to address the issue. There isn't really an established treatment for this. There is nothing that goes into the training for clinical psychologists, social workers, psychiatrists, really any kind of mental health provider that actually gives them the tools to address this problem. And that is a serious gap or lacuna in our just professional state. Now, we are in the somewhat unique position of actually having a means of helping parents to address the problem. And that occurs because there is a lot in common. There's a lot shared between that phenomenon and the anxiety or OCD that we've been talking about in children and adolescents. In both cases, we're talking about a situation where a child, or in this case an adult child, but still a child of someone, is limited and impaired by their disorder and highly, heavily accommodated by their caregiver, by their parent. In fact, in many cases, the adult with so-called failure to launch a few years ago was a child with an anxiety problem. It's an extremely common trajectory. It's not the only precursor or predictor of failure to launch. There are others as well, and I wish I could tell you the exact prevalence of each of them, but with no research on the topic, that is very hard to do. But either way, we have parents who are often the only motivated party to actually address the problem. And if you're the parent of an adult child who's not motivated to get help themselves, there's very little that you can do, right? Barring, apart from kicking them out of your house, which some parents will do, but many will not, there's very little that you can do. You can't force your adult child to go to therapy. You can hardly force a young child to go to therapy. So force an adult child to do it. You can't hospitalize them if they don't want to be hospitalized because they're not a threat or danger to anybody in any imminent way. And so the hands are tied. And the experience of most parents in this situation is that they will speak with a provider. The provider will say, well, okay, I'm happy to meet with your child. And the parents say, but he's not interested. And then the provider says, well, so how would you like me to help? So what do you want me to do? So what we have actually done is to adapt what we have learned about working with parents of younger children and of adolescents around accommodation and taking some of those same principles that apply in SPACE and applying them in this phenomenon with good success. And so parents are, through changes that they make in their behavior, are often able to promote a higher level of functioning in their child, whether that means higher education, whether it means a job, whether it means more social engagement or interaction, or just doing something productive with their time. And in the more severe cases, even a very small functional change is extremely impactful and important, because in severe cases, we're talking about adults who are living in their parents' home, but completely non-functional, often not leaving the house at all, or sometimes not even leaving the room at all, or almost at all. And so even small changes can be dramatic and impactful.
Yeah, absolutely. So as far as I wrote in the teaser that you would discuss the bed trick, which whoever I've told thus far has been pretty impressed with, of how to address kids who totally refuse to, stay in their bed at night.
Okay. Okay, so this is patent pending. This is patent pending how to get your kid to sleep in their bed. And it can be done within the context of SPACE, but doesn't have to be within like a SPACE treatment or any actual therapy. And I would encourage parents to just try to do it, even if, maybe there isn't an actual anxiety disorder or any disorder, but they're having trouble getting the kid out of their bed and into their own bed. And it's very simple. We call it the game. So you play a game, and this is a very simple game. And the point of this game is to put on a show. And the show is, we're going to make believe that you, the child, that you are going to go to sleep in your own bed, but you're not. Okay, so it's very clear and very explicit that you're not. There's no expectation that you'll actually sleep in your own bed. In fact, there's no plan to even try. But we're going to put on a show that convinces this imaginary audience that you are. So how do you do that? Well, you probably start by making sure the child has a bed to sleep in, because for children who have been sleeping in their parents' bed for a long time, very often they don't have a bed. Or maybe they have a bed, but it has been repurposed into a desk or a closet or a warehouse for something, or just a surface to put stuff down on. So we get a bed ready so that they could at least sleep there, or else the audience is not going to buy that you're actually going to sleep there if there's a bicycle on the bed. And then you get ready for bed, you brush your teeth and get into your pajamas, and then you get into bed and mom says goodnight, gives you a kiss, and leaves. So far it looks like you're going to sleep in your bed, but here's where the trick comes in. You're not going to sleep in your own bed, and mom is only going to leave for some predetermined amount of time, which can be very short and can be agreed upon together with the child. So that might be 3 minutes. You're going to stay in your bed for 3 minutes. At the end of those 3 minutes, and here parents have to be conscientious and scrupulous about this to not mess up, and so they should start a stopwatch as soon as they leave. And at the end of 3 minutes, mom comes back or dad comes back into the room, and the game is over, and now child goes back to sleep in the parent's bed, just like every other night. And if they've done that, perfect. That's all that is expected. And the next night, we do the exact same thing again. The next night, we do it again. And after we've done that for, let's say, a week or some number of days, all we do is gradually and slowly inch up on the amount of minutes that the parent is leaving for. So we started with 3 minutes, now we'll go to 5 minutes. We do 5 minutes for a week, now we can go to 7 minutes, and then we go to 10 minutes. When we get to about 10 to 15 minutes, in the majority of cases, the child falls asleep during those minutes. And when that happens, the only difference is that we're not going to wake them, right? So the parent is not going to come in and wake them up. We're just going to leave them there to sleep. If the child wakes up later in the night and wants to move to the parent's bed, perfect, that's fine. And this is also important. When the child has slept in their bed for a night, the game continues exactly the same. So it's not like, oh, great, now you slept in your bed, so now you're expected to sleep in your bed. No. You happened to fall asleep last night, that's fine. We're just continuing the game with the same 10 or 15 or whatever number of minutes it was, and we're going to do it again tonight. And we keep doing that until the child regularly falls asleep during that time. And for most families, what will occur is that they'll kind of start to forget about the game gradually. As if your child has been falling asleep during those 15 minutes for the past 3 weeks or month, you can start to forget about the game. And if they want to continue it, then fine. Then continue it. That's it. This has a very high success rate. And the reason it has such a high success rate is very simple. It's different from the way many cognitive behavioral therapists approach the challenge of moving a child from the parent's bed to their own bed. So the typical way that is often done is to put a mattress near the parent's bed and put the child on that, and then gradually inch that away from the parent's bed. So, moving it maybe a foot and then another foot and another foot, etc. Here we're doing it the other way. The reason I think that it works as well as it does is that we're creating a situation that is new for the child. We're creating a situation where the child is in their bed and they're calm. And they're calm because they know they don't have to stay there. If you say to a child, you have to lie in your bed and stay there until the morning, they're not calm, they're anxious. And that anxiety can keep them up for an hour or 2 hours or 3 hours easily, and crying and yelling, etc. Here they're not anxious because they know they only have to do this for 3 minutes and then 5 minutes, etc. When you create a situation where a child is in their bed and they're calm, if they're a little bit tired, what tends to happen is that they fall asleep. And that's it.
Love it. That was like a behavioral magic trick. There's a whole lot of them. within the training. And speaking of which, how would a therapist get trained in SPACE? And also, how would parents who are interested in this treatment modality, how would they access treatment at present?
Yes, so I strongly recommend for therapists, providers of whatever discipline, if it's relevant for them to be working with parents of children who are anxious or OCD, I would strongly recommend that if they want to try to deliver the treatment, to actually participate in one of our training workshops, which we do try to hold with as much frequency as possible, time permitting. There are actually 3 scheduled at the moment. One of them is here at Yale in January, 2 of them on the West Coast, San Francisco and LA in February. The easiest way to get that information and register is to go to the website SPACE. Can we write this somehow?
Yeah, I could put it in the message.
It's www.spacetreatment, one word, spacetreatment.net.
Okay.
On that website, they can see the information about upcoming workshops. B, if maybe they're not going to participate in one of those workshops, but they want to be kept informed about future workshops, they can also, there's a place to just put your name and email, and you'll be added to the mailing list that we maintain to let people know when another workshop is planned. Also new on that website is a forum where people can actually exchange ideas or questions or share stories relevant to SPACE. And so anybody is welcome to register for that as well. For parents looking to access treatment, I would say a couple of things. One, although I'm a little hesitant to say email me, I guess I will say email me, because I do maintain a list of providers who have participated in the training workshop. So if you want to know, has somebody in my area done this kind of training and is able to provide the treatment, if you email me, I will respond and let you know. That is a list that is obviously growing and continues to grow. The other thing I would say is, if you have a therapist that you know and you trust, or somebody that you work with, somebody in your network, etc., maybe they're not familiar with SPACE, I would recommend introducing them to it. And so you can tell them about it. There are 2 books that we've published on this. One of them actually includes the manual for SPACE. Again, my recommendation would be for somebody to actually participate in a training workshop rather than only reading a manual, because it's always going to be a little bit more limited to only read. But still, a resource they can, if you do read the book and do read the manual, they can certainly, it can inform the work that they do. And more recently, another book that really deals with the nuts and bolts of addressing accommodation, not just the manual, but gets into the, maybe, can I also write a message in the chat?
Yeah, 100%.
Okay, what I just wrote now is the first book, which also includes the manual for SPACE. By the way, a book that is written with parents as well as therapists in mind. And so definitely readable to a wider audience as well.
Oh, we have someone showing off their book. Look at that.
Holding it up. Wow.
And she still came to the speech. Awesome. Really cool. Before we take a few questions from the audience, I'm going to put all the resources and this video, I'm going to make it available on my website, myocdcare.com/learn. This can be the educational portion of my website.
The second,
I'm sorry, yeah, go on.
No, I was just saying the second title that I wrote now is a book that it's not the manual, but that one is written actually more for therapists and is really just, I think, a very practical kind of, no one's going to hold it up, nuts and bolts kind of book on addressing accommodation. The next book that will be coming out, I think, early 2020, well, sometime 2020, is actually a workbook for parents to try to work through the steps of SPACE on their own, though obviously I would recommend, when possible, working with a therapist, but a workbook that parents will be able to actually implement on their own as well.
Yeah, that's going to be so important, especially given, you know, the challenge of dissemination. And that's going to be among the topics we're going to speak about in future lectures. I guess what message would you give to parents, right, who, you know, who currently are struggling with a child who themselves are struggling with anxiety, you know, and, you know, they're told to, you know, not accommodate, and, you know, they're kind of feeling lost or hopeless. And it's just very hard to see your child go through that. And what kind of message would you give to those parents who are going through that?
You know, I would say, let's think about what's the most important thing you would want your anxious child to know, to learn? If we could say one thing and they would really believe it, what would that be? To me, for an anxious child, that would be, I can cope with anxiety. I can be okay. Maybe I will be anxious some of the time, and maybe it will be uncomfortable, but I can cope with anxiety. This is a really important message. So much of the impairment in anxiety and in OCD comes from a child not believing that they can cope with anxiety and being determined not to experience it. And if you think about it, what's the message that we give children with other illnesses, right? Nobody would say to a child diagnosed with diabetes, you can't cope with diabetes. What a horrible message, right? No one would say that. Or you can't cope with asthma when you've been diagnosed with asthma. And it's the same way we don't want to say to a child with anxiety who's likely to experience elevated levels of anxiety over their lifetime, you can't cope with anxiety. We want to say the opposite. Of course it sucks to feel anxious, but you can cope with it. And that is exactly the supportive message. When we talk about being supportive, what we mean is exactly that. Conveying to my child, I get it, it sucks, it's hard, it's uncomfortable, it's frightening, but I know that you can cope with it. And so I would recommend, if you have a child who's experiencing anxiety, whether that's a serious anxiety disorder or maybe just a more typical, occasional elevation in anxiety, try to give them that message of support. The acknowledgement, I get it, I can validate what you're experiencing, but I know that you can tolerate it. I know that you can cope with it. And remember that you are the mirror your child is looking into and seeing who they are. And if they look at you and they see themselves reflected to themselves as a vulnerable, weak child who's not able to cope, they will believe that and they will be tormented by their anxiety even more. If they look in that mirror and they see I'm a capable child who's able to cope, yes, will sometimes be anxious and that's uncomfortable, but I'm able to cope, then they will believe that and their anxiety will be diminished.
Yeah, that's very powerful. Does anyone in the audience have a question or so? I saw one, can the workshops be online or only in person? As far as I know.
Very good question, which we get a lot. So at the moment, the workshops are in person. We are working on trying to be able to offer online participation. And as soon as I figure out all the details of that, we will definitely want to do that as well. It goes back to the access to, in this case, access to training rather than access to treatment, but kind of the same issue. So it is something I want to be able to do, but have not yet. So for these upcoming workshops, it is in person.
Okay, awesome. Thank you so much for your time. This was really great. Tomorrow night, we have Dr. Steve Hayes, the inventor of ACT, who's going to be stopping by to answer some questions about his new book. All the information that we had discussed, this recording is going to be made available, hopefully both in video and also in podcast form. Thank you so much, Dr. Lebowitz, for taking the time and for teaching us about this really helpful training that I would really hope spreads and really gives that message of empowerment to parents that they could do so much in helping their children, and it's not, necessarily dependent on that therapist, but that they themselves have tremendous power with the assistance of the therapist.
Well, thank you very much for having me.
Yeah.
And for hosting this and for putting me before Stephen Hayes, because that's a tough act to follow.
Yeah.
and
got it.
putting this whole series together, which is fantastic.
All right, wonderful. Okay, thank you so much, and thanks for everyone for joining, and have a good night.
Bye-bye.
You need it. Start out.